brush up what we have studied in the last class. Okay, so we will continue those who are absent and we will be refreshing for the others. So autonomic nervous system, we know it is also called as sympathetic system. We have studied about different group of drugs which can act on this autonomic nervous system. We have started with the cholinergic system, anticholinergic and anticholinergic drugs. So today we will be discussing about the adrenergic group of drugs. Okay. So we have discussed them under three headings: directly acting, indirectly acting, and mixed group of drugs. Okay. Directly acting, we have the alpha and beta agonists. Okay. So we have the drugs which can act on both alpha and beta receptors, adrenaline, epinephrine. Thank you. So alpha receptor, phenylephrine, it is the drug which we use in our pharmacology for diabetic mydriasis. Okay. So we have isoprenaline and adrenaline. So indirect acting drugs we have ephedrine and tyramine. So mixed group of drugs we have this amphetamines. So we are dealing with the sympathetic division, where the pre-ganglionic fibers carry acetylcholine and the post-ganglionic fibers are carrying the adrenergic neurotransmitters, that is adrenaline, noradrenaline and dopamine. So here we are speaking about the sympathetic system which can dilate the pupil. We have this phenylephrine and decrease the salivation, increase the respiratory rate. We have the salbutamol, salmeterol, all these things, increase the heart rate. We are going for the dopamine, dopamine, all these group of drugs. Constrict the blood vessels. We can use this adrenaline and its continuous in 1:10% concentration for the local vasoconstriction. In the digestive process, we have the group of drugs called as analytic agents, that is sibutramine, fenfluramine, dextroamphetamine. Okay, so in case of this bladder, drugs which can act on this bladder, we have the antagonists which are more commonly used. So we have this therapeutic classification of the drugs. Okay, this is the most common classification asked in your viva. The first thing you can come from head to toe. Okay, first in the eyes, that will be phenylephrine. Then go to the nose, that will be, well, you can go after eyes, you can go to the brain, that is the CNS stimulants, that will be amphetamines. Okay, amphetamines, you know there are so many drugs here. Then comes the nasal part, we have nasal decongestants. Okay, that is oxymetazoline, xylometazoline, all these group of drugs. Okay, then we have the drugs which can decrease the salivation and also decrease the appetite. Okay, those group of drugs are the anoretic agents. Then we have the heart. Okay, heart and the pressor agents, which here you can see this is noradrenaline, phenylephrine, and cardiac stimulants we have non-selective adrenaline, acetylcholine. Then we have dopamine and dopamine. Then comes the respiratory system. We have the bronchodilators. Okay, salbutamol, salmeterol, all these things. So then we have the appetite suppressant coming to the GIT. Then we have the uterine relaxants. Okay, uterine relaxants we have azoxystrine, Ephedrine, salbutamol, all these group of drugs. So this is an important point we need to remember, where noradrenaline can act, where adrenaline can act. So as this adrenaline has all action on all the receptors, starting from alpha and beta receptors, we are told that based on the alpha receptor action, we are having vasoconstriction and raising the blood pressure. Based on the beta 2 action, which is more prominent at the slightly lower doses, we are decreasing the blood pressure. So based on this, if we can use it with alpha blocker there, we can have vasomotor reversal of where there will be continuous fall in blood pressure. Okay, you need to remember noradrenaline, no action on beta, acetylcholine, no alpha action. So in this chart, we have studied about the synthesis of this epinephrine. Okay, starting with tyrosine, phenylephrine. Okay, phenylephrine or tyrosine. Then we have this dopa, which is a precursor of dopamine. Then dopamine. From the dopamine we get noradrenaline. Okay, from noradrenaline we can get adrenaline. Okay, this simple step. Okay, first we have this phenylephrine, then tyrosine. Okay, phenylephrine, tyrosine, then dopamine, noradrenaline, and adrenaline. So here, where it is stored, we have the drugs which can act as indirect sympathomimetic drugs. That is Ephedrine and Tyramine. Okay, mixed kind of drugs, that is amphetamines, can also act on these vesicles. Okay, then we have the release of these neurotransmitters. Once this neurotransmitter is released, we have three sites of action. One is the postganglionic neuron, one is the autoreceptor, one more is the norepinephrine transporter back for its metabolism. Okay, on all these sites, it can act. The autoreceptors can regulate the release of this drug. Okay, then the reuptake will be for metabolism. Then metabolism inward, we have two important enzymes, that is monoamine oxidase and catechol-O-methyl transferases. Okay, so here is the steps. Okay, tyrosine, dopamine, dopamine to norepinephrine, norepinephrine to epinephrine. So that's the step. And we also told that in the last class, based on the metabolites which will be released in various disease processes, we can make out which disease is it. Okay, whether the metabolite has decreased or increased. Based on that, yes, that's it. Okay, based on that end product, we can find out which disease we are dealing with and what will be the metabolically. Okay, come to the drug targets, that's enzymes which can metabolize it. Okay, then here we have just any non-reuptake, that is for metabolism. Then the drugs which can inhibit at this step. Okay, reuptake can be inhibited by three group of drugs, that is cocaine, which is the abuse drug, tricyclic antidepressants. Okay, the most commonly used antidepressants in the earlier past. Now we have better alternatives. Still, they are used amitriptyline, norepinephrine, all these form tricyclic antidepressants. Amphetamines we have. This vesicular uptake can be inhibited by reserpine. Okay. Then this extraneuronal uptake that can be inhibited by steroids and phenoxybenzamide. So the two important enzymes you need to remember, monoamine oxidase and catechol-O-methyl transferase. Okay, these enzymes, what they are doing, they are increasing the actual dopamine level. Where do we need to increase the dopamine level? Which disease? Okay, so Parkinsonism, can we use the blockers for this? Yes. So the Parkinsonism, we already know that dopa. What are the two drugs? Carbidopa, levodopa, you know. Okay. Other than that, we have this monoamine oxidase inhibitors, that is tranexipramine, selegiline, clozulin. For catechol-O-methyl transferase, we have this tonicapone and entacapone. So this is the synthesis step. You need to be here. This diagram is for showing the inhibitors. Okay. So tyrosine hydroxylase, which converts tyrosine to dopa, that is inhibited by tyrosine. Then reserpine, you can inhibit this vesicular uptake of this dopamine. Okay. Then we have reuptake inhibitors, that is cocaine and tricyclic antidepressants. So if you can put this diagram, it will fetch you 4 marks. Okay. So this diagram we are telling about, there is heterologous desensitization and homologous desensitization after prolonged use of this drug. Just remember only two steps. Okay. So alpha receptors, where they are present, beta receptors, where they are present. Where beta 1 receptor is present? Heart and JG apparatus. JG apparatus is juxtaglomeralular apparatus. Okay. Where alpha 1 receptor, alpha 2 receptors, where they are present? So I have not put that diagram. Okay, sorry for that. So alpha 1 receptors, preganglionic or postganglionic, which is present in glands. Beta 2 receptors, vessels, bronchi, uterus, liver, GIT. Okay. So adrenergic system, you need to remember where they are present, why uses are there. Okay. So interreacting drugs, we already told which group of drugs are acting, how they are acting, mechanism we saw. So the classical graph which we will be having in your practicals will be the Ephedrine graph. Okay. So what happens when you give repeatedly, the stored catecholamines, that is noradrenaline, can be released from the synaptic post preganglionic neurons, and there will be gradual depletion of this stored acyclic catecholamines, and there will be decreased response, and with this we get the regret. Okay, so then we have this Tyramine. This part I will tell you. Okay, so Tyramine is again similar drug which can act like this, indirect sympathomimetic or release of the stored catecholamines. Okay, so here we have a concept called as cheese reaction. Okay, the cheese which is kept for a longer time. Okay, maybe we have yogurt, dressings, liver, pickle, dry sausage. All these are the sources of this Tyramine. Okay, so these are the sources of Tyramine, and once this Tyramine levels in the blood can increase, okay, there can be sudden release. This sudden release will be possible because of the indirect action. Okay, they are just pushing out the stored catecholamines. Okay, once the stored catecholamines can be released, what can happen? There will be sudden increase in the levels of noradrenaline and adrenaline in the blood. Okay, this sudden increase can cause. I don't want to hear noise. If you have one, you can ask me. This sudden increase can cause hypertensive crisis. Okay, it can be in the form of palpitations, all these things. Okay, so palpitations, arrhythmia, all these things can happen. So this can also be aggravated by the drugs which can increase their catecholamines. Example, the MAO inhibitors. Okay, MAO inhibitors or the catechol transferase inhibitors. Okay, all these things, if they can increase the level of catecholamines, they can lead to hypertensive crisis. Okay, arrhythmia, stroke can happen, and patient is receiving this MAO inhibitors and tricyclic antidepressants. All these people can have the symptom, and at that time, if you can have, if the person is already suffering with all this in early 40s or 50s, and with hypertension, he goes for a pizza or anything which contains high amount of cheese, then the person can get this disease or a sudden reaction. So adrenergic system, yes, here is there. Here also we do not have this where they are present, but alpha 2 remember is dysynaptic. So relating these things we have discussed, what is happening here. Okay. So epinephrine. So cardiac activity. Okay, where we are using this. Commonly we are using this dopamine or dopamine. Okay, and most of these reactions, what we are telling, they are demonstrated by intravenous administration of this adrenaline. So if not adrenaline, you can use some antidote. For example, in case of atropine, if not atropine, we are using the drugs which are having lesser side effects and better, only carry out the better effects. That may be in the form of dopamine or dopamine, okay, or isoprenaline. So here they have chronotropic effect, inotropic effect. Okay, both heart rate is increased and contractility is also increased. Okay, so totally what they will be doing, they will be increasing the stroke volume, and that means the volume which is carried out for the injection. So increased workload, increased oxygen demand. So increased workload, increased oxygen demand, that can be helpful in hypovolemic shock or accidental conditions, but not in cardiac failure. That point we need to remember. Okay. So this is the alpha 1 can increase the arterial resistance, beta 1 increase the heart rate, beta 2 decreasing the BPM. So this we discussed vasomotor reversal of play. Here using the here we are showing the action of which drug? Adrenaline. Just remember vasomotor reversal of play. They are demonstrating the effect of adrenaline. So adrenaline at just forget this. This is there. Just you see the black line here. This black line demonstrates the normal response of the adrenaline. Then it is given. Okay. Initial alpha mediated action rising the blood pressure, followed by beta mediated falling the blood pressure. Beta 2 mediated falling the blood pressure. But later, if you can use the alpha blocker there, there will be no alpha mediated action, only falling the blood pressure. Okay. That is the vasomotor reversal of play. The alpha effect is reversed by using alpha blocker. Okay. So blood vessels at other different parts, what can happen? That is there. Okay. You can use mucous membrane, all they can get constricted. That's why we can use, for example, epistaxis is there. What is epistaxis? So what we can do? We can use a cotton swab, take adrenaline in 1:10,000 strength. Okay. Put 2 drops. We can use it there. Okay. That is the normal thing what they do in EAD. So CNS, we told amphetamines, they can stimulate the CNS. Okay. The catecholamines, other than this amphetamines, they never cross this blood-brain barrier. But the common thing what we use really, amphetamines will be caffeine, okay, or the coffee. So they have the stimulant effect. They can cause anorexia, euphoria, and insomnia. Very high doses they can go for anxiety, confusions. So the classical effect on the eye is shown by the drug phenylephrine. We told that here it can cause mydriasis, which can be direct. Adrenergic drug here is phenylephrine. Okay? Sorry. Okay. Yes, they are written mydriasis, which is direct. Okay. That's what we are demonstrating in our practicals. Okay. So in the last class we also discussed about how the drugs which can be helpful in this glaucoma. Okay, the antagonists rather than the agonists will be helpful there. Okay, that how they are better than the myotic agents. So respiratory tract we have discussed about this salbutamol, salmeterol. What is the economical significance of this salbutamol, salmeterol? Genitourinary tract. Okay, so what they can do? They can mediate the contraction and cause urinary retention. So amphetamines, in the last class, this was the last slide I remember. So we can be used most commonly they are used as a CNS stimulant. Initially we can give in case of sleepy disease or sleeplessness or all things, but when they are abused, they have side effects. Okay. So meth, you remember this. Okay, very similar to amphetamine, it can cause CNS stimulation. So the indication is ADHD. ADHD means attention deficit hyperkinetic disease in children, where the children will be highly overactive. Okay, so the side effects will be insomnia, decrease of appetite, all these things. So coming to the adrenaline. Okay, adrenaline is a drug of choice for our anaphylactic shock. So the strength we need to remember is 1:1000. Okay. So 1:1000, 0.5 ml in intramuscularly given in adults. So 0.3 ml we tried in children. Most commonly the route of administration will be intramuscular. So if the patient has not recovered, okay, the anaphylactic symptoms are not improving, we can try the drug again after 10 to 15 minutes. So here, IV, it will be fatal because of ventricular fibrillation and all. So you need to remember, if the patient is aged person, we need to think of these conditions before administering this drug: hyperthyroidism, hypertension, and arrhythmias. So most of the obese people in to get hypertension, or they may not be in undiagnosed pre-hypertensive state. So if you have a patient with anaphylaxis on the bed, consider these points. Okay. Then we can use this for local bleeding. That's what we are explaining in epistaxis. Then we have this local anesthetic action. Okay, for suturing purpose, they do this. Okay, so along with the xylazine, they have the mixed concentration actually. Along with xylazine, this adrenaline is already in the mix. It comes in the ready preparation. Okay, so here the concentration of adrenaline will be 1:2 lakhs. So the next drug is alpha-1 agonist-phenylephrine. Okay, so we know that basic things. Okay. One is that we are using for demonstration of this direct mydriasis. Then it is resistant to monoamine oxidase and catechol-methyl transferase. That means it can be used orally. Okay, so relatively long duration of action. Then it can lead to rising in blood pressure as with other catechol-amine, and once withdrawn, it can lead to reflex bradycardia. This is very important when we are using this clonidine. Okay, I will tell about this reflex rebound hypertension and reflex bradycardia. So this can produce mydriasis and nasal decongestion. So it can be used in shock because of this rising BP. So mydriatic in the form of high pressure, eye drop, as I told, they cannot cross the blood-brain barrier. So the side effects are photosensitivity, congenital hyperemia, and hypersensitivity. In 18 few of the drugs which can cause this photosensitivity. Okay, the one drug is this one, and we also have this tetracyclines. So selective alpha-2 agonist, alpha-methyl dopa, as it does not cross the placental barrier, it will be the drug most commonly used in cases of pregnancy-induced hypertension or gestational hypertension, pre-hypertension, all these conditions in pregnancies. Alpha-methyl dopa, alpha-2 agonist, it can act as an antihypertensive agent. So these are the centrally acting drugs. Okay, so actually you might get a doubt when we are speaking about this anti-adrenergic agents which can be used as antihypertensive agents. Okay, those will be the drugs which will be acting on the peripheral resistance. Okay, so the alpha blockers which are commonly used as antihypertensive agents, they are the peripheral acting agents. So here it is a centrally acting agent. Just remember, it is a centrally acting agent. Then the non-selective alpha agonists, oxymetazoline, xylmetazolene, nasodium, last class we told is the most popular nasal decongestant. They cause vasoconstriction and nasal decongestion. So due to this allergic reaction, what happens? The allergic mediators with prostaglandin system which is released, they can swell up the local blood vessels. So by using these local drops, we can get rid of this nasal decongestion. So cocaine, just important point about this is use a local anesthetic, peripheral sympathomimetic action. We just remember the previous slide where we are shown that cocaine, tricyclic antidepressants, they are blocking this. Where they were blocking? Non-epinephrine reuptake step. Okay, at that stage they were acting. That means they are increasing the non-epinephrine levels, and this can lead to euphoric effect. And this euphoric effect, it is abuse drug. Okay, so the major action of cocaine is in the central nervous system to eliminate the dopamine reuptake in the neurons in the pleasure centers. So isoprenaline, also called as isoproterenol. Okay, we know that where this isoprenaline is acting, beta 1 to 3. Okay, so beta receptors work normally. Just remember, it doesn't have alpha actions. Okay, orally effective, potent, long acting beta receptor agonist, and has little effect on alpha receptors. So whenever we are speaking that they are acting on alpha or beta receptors, it means that their prominent action is on those receptors. So it leads to marked increase in the cardiac output, So you can use for the shock conditions. Okay, it can be used for uterine relaxants. Okay, we told that beta agonists are helpful as a uterine relaxant. We can use it in threatened abortion and dysmenorrhea. The adverse effects may be in the form of tachycardia, flushing, and hypertension. Based on this beta 2 receptors, we can get this hypotension. So dopamine, we need to remember dopamine at different doses has different actions. The most common dosage what we give in the form of IV infusion will be around 3 to 7 micrograms. Okay, 3 to 7 micrograms we are giving in the form of IV infusion in case of hypotension or hypovolemic shock. So here 2 to 5 micrograms, okay, it can stimulate the D1 receptors, renal mesenteric, and lead to vasodilatation. So the next effect will be increasing the renal blood flow, GFR, and causes natriuresis. But at moderate doses, that is what I was telling about the 7 microgram dosage, positive inotropic and chronotropic effect is there. Okay, so this will help in raising the blood pressures. So that means these are the drugs with very narrow therapeutic margin, and here is the drug. Even though it is a narrow therapeutic margin, we have to maintain sufficient concentration of the drug, that is moderate dose, to get the required benefit. Okay, so that required benefit will be in the form of chronotropic and inotropic effect. But at that low dose, it can be like natriuresis and all. What can happen? Again, further deterioration can happen. Okay, so users, we are going for these drugs for this hypovolemic and shock and cardiac failure. Okay, at very high doses, it can cause the vasoconstriction and decreasing the renal blood flow. In case of this hypovolemia, the normal urinary output should be maintained. Okay, that is very important. And if once renal failure, it goes for renal failure, we cannot revert back the patients. So dopamine is one more this sympathomimetic drug. Here, though it is a derivative of this dopamine, it doesn't act on this D1 or D2 receptors, and it has both alpha and beta action, but more commonly here beta 1 receptor. Beta 1 receptor means cardioselective. Okay, beta 1 action is on heart and JJ apparatus. Heart means inotropic action. Okay, more contractility. So just remember basic things. Okay, the half-life here is 2 minutes. So we are giving it by IV infusion. So we are using it for cardiac shock, MI, cardiac surgery, and patient with CCF. Okay, in patient with CCF, we need to remember the inotropic action is more important. Okay, if the cardiac workload is increased, there can be problems. So it can be avoided in hypertension and cardiac dysarrhythmias. Dopamine derivative does not act on dopamine receptors, more action on beta 1 receptor, inotropic action used in cardiogenic shock. So alpha 2 agonist, something like methyl we saw. Okay, it is a centrally acting agent. Okay, here clonidine reduces the blood pressure. It is a centrally acting alpha 2 agonist which can decrease the blood pressure. Okay, so it is an agonist at postsynaptic alpha adrenal receptors in the brain and suppresses sympathetic flow and reduces blood pressure. By alpha action, central CNS action, in between you two. Who is that? Yes. Stand up. Yes, sir. Second person was bending down. Yes. So here we need to remember an important concept called as rebound hypertension. Okay. When we are using the drug, these were the drugs which were used previously, not now. Okay. Now we have better drugs, maybe the angiotensin or the renin receptor blockers. Okay, so direct angiotensin receptor blockers. These are now we have better drugs. The beta blockers, though they had some adverse effects, the non-selective anti-sympathomimetic like anti-adrenergic drug reviews, they have also had very much side effects, and now we have the specific drugs which are better. But these are the importance because the examiners will be tending to know whether you know that or not. Okay, the concept is rebound hypertension. If you stop this, any other centrally acting drugs, there will be some rebound phenomena. For example, like we were telling about this tricyclic antidepressants. Okay, or the cocaine, which we saw in the previous slide. Cocaine, tricyclic antidepressants, or the Clonidine which we are using. They always have the tendency to form rebound phenomena. Okay, so rebound hypertension is the particular term which is used for this Clonidine. Okay, so Clonidine, centrally acting antihypertensive drug, which when stopped abruptly can cause rebound hypertension. Okay, so agonist to post-synaptic alpha-adrenergic receptor in the brain. Okay, at high doses, it can cause peripheral presynaptic autoreceptors on the adrenergic nerve endings. Here the net action is decrease the sympathetic release and reduce the blood pressure. Okay, so overdose stimulates the peripheral postsynaptic alpha receptors. So peripheral means on tension of the alpha receptors, and it can lead to hypertension. So abrupt or gradual withdrawal causes rebound hypertension. Okay, so here the drugs which are used for this hypertension, for example beta blockers or any other blockers, their action will be seen after 15 to 20 days. Minimum time gap will be there so that the